I think we've beat this issue of bone loss to death, but I just wanted to bring it up about Burkhardt and De Beer have taught us that bone loss is critical and it's important, and we have to address it or we can have a really high failure, especially in contact athletes. But what is a critical bone loss? I think that's a moving target because it's not just one factor. It's not the same number for every patient. It depends on age, contact athlete, activity level, and the laxity of the joint. So a 17-year-old contact athlete, that critical bone loss is 10%. Whereas a 45-year-old is non-contact, that could be as high as 20%. So we have to really individualize our care and treatment. So why do Latarjet? I think it's a triple threat. It addresses the bone defect. You get a sling effect, which I really believe in, and you also have great fixation of the bone block to the glenoid. It restores the architecture and the arc and restores the glenoid tract. So what are the outcomes of Latarjet? The results are just irrefutable. The recurrence rate is so low. In Walsh's series of over 3,500 patients, it was 1.2%. And with a large systematic review of 2,500 procedures, it was 1.5% redislocation. So why aren't we doing it in the U.S.? And I think it's because we've all become arthroscopic surgeons, so this is a non-arthroscopic procedure, unless your Granton is going to show us how to do it arthroscopically. It's a very elegant talk that's coming up. And also the complications. I think we're all scared of these complications, but we shouldn't be. And I think what really set the alarm off was this near award-winning paper out of Mass General with JP and Ruth Delaney. And they did neuromonitoring, and they found like significant nerve alerts during the procedures. But if you read the paper, all of those nerve alerts, or even if they're transient palsies, they all resolve completely. So we really shouldn't be scared. And another a systematic review of over 7,000 shoulders, the overall complication was only 6%, and less than 1% was nerve-related. So we really shouldn't be afraid of these complications. So if you're going to do it, you want to avoid complications, you got to do it right. I think subscap management is very critical. There's different ways that have been described. But splitting the subscap is definitely the best way to do it. You want to go between the upper 2/3 and the lower 1/3. If there's a lot of instability or laxity, you can make that split even a little higher. The higher you go, the tighter the shoulder will become. This is a less traumatic way. Instead of taking the subscap down, less risk of rupture of the subscap. It allows for early and aggressive physical therapy, and it reduces the risk of fatty infiltration, which has been reported to be as high as 41% if you take the subscap down. Again, and this is Ian Hurley, is just systematic review and meta-analysis guru. He's done, I don't know how many hundreds of these, but looking at 615 shoulders, there was significantly better functional outcomes with the split instead of the takedown, lower rates of subscap insufficiency, and lower rates of recurrent instability with the split. How about the coracoid osteotomy? You want to be just anterior to the CC ligaments. You end up usually with a 20 or 25 millimeter bone block. I use the osteotomy, but it's personal preference. You can also use the 90-degree saw blade. But if you do, when I do the osteotomy, this is what I'm looking for. That's how I know I've gone posterior enough. You have this large spike of bone that's coming off at the base of the coracoid, which you can trim off. But that's how I know I've gone back enough and I'm going to have a big enough piece. Just for reference, a bristow is a smaller piece of the coracoid. It's one screw fixation. So if your bone block does happen to break, don't panic. It still works. You just have a smaller surface of bone for healing. But when I was a fellow at Curl and Job, that was their workhorse for shoulder instability, was the bristow. So they had done thousands of bristos, and patients did well. The classic Latarjet is the inferior surface of the coracoid is what's placed onto the anterior surface of the glenoid, and this is my preference because it provides a larger surface to place the screw holes through, and also provides a larger surface of contact between the coracoid and the glenoid. And you can, if you believe in it, you can also repair the CA ligament to the remnant capsule. The congruent arc, which was described by Burkhardt, uses the two screws, but you put the graft on end, so you rotate it 90 degrees, and it better matches the inferior surface, better matches the curvature of the glenoid. So if you believe that you're extending the arc of the glenoid, this is a way to do it. I've had trouble because putting the screws in, you're putting it into a much narrower surface of bone, so I always worry about my screw breaking out. So that's why I just use the classic Latarjet. As far as outcomes, there's no difference between the congruent arc or the traditional Latarjet as far as redislocations and patient-reported outcome scores. Capsular management, this is Gilles Walsh's modification of the classic Latarjet of repairing the CA ligament. I've tried to do that a couple of times, but by the time you put sutures through it, that tiny little ligament is gone. So my preference is to put an anchor and reattach the native capsule to the anterior native glenoid, so placing the bone block in an extra-articular position. The other complications are graft malposition. The key is not to lateralize it. You don't want it to overhang into the joint. That can lead to arthritis very early on. So you want to medialize it 1 to 2 millimeters, and that gives you just enough space to put an anchor in and reattach the capsule as well. I always use I use X-ray, but you can use fluoro. That confirms my graft placement, my screw position, the screw length, and I use these guides. I don't have anything financially to disclose, but these guides are very helpful to make sure that you have it just a bit medial and you're not going to overhang into the joint. As far as non-union of the graft, in my cases that I get X-rays on, they're rare. I do not get routine CTs on these patients, but I really take the time to decorticate or roughen up the undersurface of the coracoid to a bleeding cancellous bed. I think 2 screws gives you better compression and better fixation, and I put it in a classic position for a larger surface area. And again, I don't have any financial conflict with this, but I really believe in using this plate because it acts as a giant washer and it spreads out the forces of the 2 screws onto the graft. So it provides better compression, in my opinion, of the graft. So I use this routinely. Thank you.